the top 5 gynecomastia medical mistakes that I see over 20 years as a physician taking care of men on androgens. This is going to be very important, especially for young men that are new to this. They hear about gyno and they're going to be starting the road of androgens, or even middle-aged men, hopefully not young men, but I think it's reality. So many men are getting on testosterone, and then this gyno, this estrogen world is going to come into play. I want to do a great job here for you guys here. So in the 5th position, all the way up to number 1, let's start down at the bottom at number 5. This is going to be differentiating gynecomastia versus just fat, just your body, male boobs, man boobs. It's very difficult sometimes to really understand. Gynecomastia, let me explain, is a mass and or a sensational effect of the estrogen on the mammillary gland, okay? And that's obviously a mass. If you look at what's going on from puberty for young men, so many, I believe it's half or more, they can have this transient gynecomastia. It depends on so many variables. If they're very, very, very lean and they could see, like under the lights or in their shirt, that they have this little bit of gyno coming out, and it's even irritating to them because it doesn't look good, and it's a little bit of a little bit like a extension of the nipple, right? That's gyno. Or they have a little mass and it's painful. It's gyno. But if you're heavy, if you're overweight, not to mention you have this on top of it, and your whole chest region is just enlarged and fat, and that's part of your body habitus. This is going to be hard for so many men. They come to me and doc, and they're referring to the gyno, and I'm like, sir, let me take your shirt off and let's work on this. Here's where gyno is, and your whole breast here is, you have fat, say in the side here under the arm, when it comes under the axilla, right, the armpit, and they're thinking this is all gyno, right, doc? No. That's your body. So again, number 5th position is, for an example, not understanding what real gyno is, the sensation, the mass, where it is, and of course the effects and the drugs we're going to go into, but using an anti-estrogen to reshape your chest, that is going to be a massive medical mistake. Not to mention, you'll feel bad and there'll be a diminished return. You will not have an effect, and then you're going to be so frustrated and depressed. That's why I had to make this video. So what you can do is you can understand and differentiate real gynecomastia itself from an enlarged fat breast or a male boob, if you will. I want you guys to really understand that. Now, of course, some of it is going to be in together. You're going to have a male boob and a fatter, heavier, fat-laden body habitus chest with superimposed gynecomastia. Yeah. Now, every man's different. The way my nipples sit kind of underneath my chest, I'm just so damn lucky. So I don't really get, even though I've done at points in my life like 750 milligrams of test, probably was Sustanon, and I felt it, sensation. It was burning. Wow, this is burning. This feels terrible. It burns. We're going to get into that later in the discussion here. But I never, because my nipples are underneath. You see guys with the shirts on, with the t-shirt, and the nipples are sticking out. Well, that's gyno, part of it. It's definitely related to it, right? It's a telltale sign of the celebrities, right? The nipples are sticking up. Yeah, it can be. Or is he cold? Is he just in a cold room? Or is it just genetic? You see, there's so much on a spectrum from the nipple anatomy, your body habitus, your body fat, and of course the drugs, the steroids, right? So we're going to get into that today. So what can you do? What can you do is you understand this. you need to change your body the best you can with diet and exercise, cardio for weight loss, strength training and weights in the chest and shoulders to really build up great chest, right? And that's where these influencers are great. You look at their bodies and you see, the athlete guy and all these, ripped and just getting ripped and training, right? Right. So that's you're understanding the diet, exercise, and behavior, trying to lose weight. And then the feature I want to say, what I want to get along here for this is, before we move on, is understanding, be patient with yourself and tolerant and accept yourself and love yourself. You're all you have. As you get older, this typically gets better. Don't beat yourself up too much. You could beat yourself to be tough and to be critical for positive motion. There's that edge where people are critical of themselves and abusive, and it just deteriorates yourself. So as you get older, you see this. This is why the beauty of hopefully what I'm bringing to you guys, to really be self-accepted. If you're a little bit overweight and you have some gyno, don't wear that shirt, or train around it, or of course health is always number one, but you want to look your best and really figure out how to work around that. And that's where, when you've lost the weight, you've trained the hardest, you've accepted yourself, laugh at yourself, take care of your health, be good to yourself, and love others. And then in the end, go see a damn plastic surgeon. And you can't reshape your chest with Anastrazole. I mean, you could knock down some gyno. Is it worth it with the health risks and your brain and your libido? You see all the comments. I know you will on this one, especially this one. So, but what's really happening? Is it your body habitus, or is it gyno? And are you really making the steps to get there and accept yourself the whole way? And then when you're at a certain point, if you could afford it or do the best you can, go to a plastic surgeon. A very good plastic surgeon is amazing at working on it. We do it for the face, right? Maybe I did some of the stuff, right? So it's like, you want to feel great. So plastic surgeons are there. I mean, I should do videos on great plastic surgeons. Some of the guys are over the top, and don't you look at people sometimes, and especially the women, sorry, and you go, whoa, holy shit. The guys too, I guess. Who the hell, what surgeon did this? Is that illegal? Is that like medical malpractice? Like, who does this? But people want this stuff, right? But if you get a great plastic surgeon that's just an artist and a good guy, and I have them right here in South Florida, and they're artists and they work, and you feel great about yourself, right? Gynecomastia plastic surgeons, they're not going to be the best guys in the face. You can't do everything. So that's specialized surgeon. Just a gyno guy. There's a limited number in the country, from my opinion. Okay, up in the fourth position, gynecomastia. What is it? Sensational, where you feel it, versus the mass. Let's go into it. So, testosterone and steroids are going to cause gyno. There's usually, from the sensational standpoint, it's transient, where you're going to feel. I still feel it from time to time throughout a month or so. It's burning, it's aching. The next thing I know, it's gone. Transient, it's moving through. Or is it chronic? Not to mention, for that painful, the burning, you can't live that way, right? So that's why we're doing the video. So, and then the next one is a mass. So there's the sensation, boom, versus a mass. Wow, I have a mass right there. Oh shit. So to me, as an internal medicine doctor, as I'm trained, you have a mass. Of course, is it tender, not tender? Is it fixed? Is it movable? All these things that we could characterize as healthcare providers to be less concerning, and so on and so forth. Forget it. A mass, to me, you have to think, God forbid, cancer, and to proven otherwise, 1% of breast cancer are men. 1%. That is a number. I've never seen a guy on steroids or testosterone have breast cancer, but I've seen guys come to me with the nipples bleeding. And that's like, if you're a woman or even a man and you're not on, typically who were these guys? They're law enforcement guys, and they have the heavy vest on, and it's rubbing on the nipples, even with an undershirt underneath, and it's caused bleeding. Or some of the strong men, they're wearing these apparatuses, and it's caused bleeding. So it's like, but you can't just, it's fine. Bleeding breast mass is like, that's cancer. That's breast cancer to proven otherwise. So you have to appropriately work that up, and you just go to a general surgeon and they'll take charge from there to a breast surgeon, or what they're going to do with mammograms and ultrasounds and MRIs and biopsies. But again, guys, you have to be careful with that. So most of the gynecomastia, right, it's going to be a mass, and the nipple's sticking out a little bit, and it looks bad when the shirt's off, and and then it hurts, and it's that sensational. I'm doing this for you guys. And then you have to understand that where it comes from, and with your body, that's number 5. Number 4 here, you can use anti-estrogens appropriately and sparing. And we're going to move on to that. But the medical mistake here is that there's a mass and you're not addressing it. You know, that's where the doctor's not addressing it. God forbid you're that one that I've never seen. That's just how a good doctor has it. It's a number game. All right, so that's number 4, the sensational, the transient, hopefully, and changing the doses, the pain and the sensation versus that mass. Don't miss that mass. In the third position, medical mistake number 3, understanding the drugs. This is all the drugs, right? The testosterone esters, all the way through to the anabolic steroid classes, the DHT derived, the NOR19 derived steroids, and then of course, the synergy of these drugs working together. So here's something that I've concluded years ago. You take testosterone esters, they are estrogenic. That's number 1. Dose is everything. And I call it the estrogen tax. Any of you guys that are my patients, or you've done consults with me, so many thousands of you men, thank you so much for allowing me to take care of you. You guys trusted me, and so I could learn so much. That's why I'm here today. I came up with, if you take too much testosterone, that 200 or even more, 400 a week of cypionate, enanthate, succinon 250, you're going to pay the estrogen tax. And then you're going to have to, so what, we give the anti-estrogens, right, doc? Well, no, lower the dose. It was from when my accountant said to me years ago, I asked him, I said, hey, Steve, I want some more deductions. You know, we're doing this, we're doing that, we're making some money. He said, no, doctor, I give you your deductions. I know the laws. I'm an accountant, and he wants to be a good one. He said, but you can't just think you're not going to make more and more money. You're going to pay some taxes. Ooh, boom, I thought. Because you don't want to get an audit from the IRS, and he doesn't want us to get an audit because it's going to look bad for him. Okay, so I thought, you make money, you got to pay some taxes. We're not going to go into the politics on that, guys. You can get your deductions. Get a good accountant like I've found. It took me a long time. So, and I've worked with some great accountants because they're not all bad, but I've had some guys that have been great. So, in the end of the day, you have to understand testosterone is estrogenic itself. You take too much, it's going to cause estrogen side effects. So back down those doses and microdose. Okay, next, other estrogenic steroids, anabolic steroids. Dianabol is the best example. There are others. Now it gets complicated when you start adding Test and Deca, Test and other NOR19, not to mention Test and Tren. Like the drugs themselves, say for an example, decadurabolin, right? NOR19, not to mention Tren. Decadurabolin is not really technically estrogenic. It's progestonic. So, but if you take Test and Deca, guys will complain, depending on what part of the cycle and how much they're on and who they are, that they have rip-roaring gyno and they're puffy as all get out. They're just completely puffed. The head grows like 2 sizes. That's all water. But Deca is really not estrogenic. Tren is not estrogenic at all. And they use that with testosterone to different degrees. These are pro bodybuilders, which I am not. I don't really know that world of the full drugs that these guys, I see the end results, which is terrible for the body, but they put these things together depending on who you are, and you're going to get different degrees of estrogenicity. So that is really the synergy of looking at this. So anabolic steroid A plus B ends up affecting the estrogen, either down or up. The classic combination that I do talk about is using DHT-derived drugs with testosterone, typically a little bit of testosterone. That's the addition of Masteron, Proviron, or Primobolan. And let's get the comments. I mean, and I've done videos on these classic synergistic additives. Men, the classic DHT-derived, Proviron as an anti-estrogen, it's not a mass drug, it's an anti-estrogenic drug, and it's true. Not to mention some of these drugs could liberate the free testosterone, but you guys have to understand, when you're in this combination synergy of milieu of combining different steroids in different classes, there's going to be effects that are going to be different based on your fingerprint. Not to mention, do you really know the drugs you're getting from the market you're getting it from? Is it really not counterfeit drug? It's so important. Okay, that was number three. Number two, let's talk about the SERMs, the selective estrogen receptor modulators. They're going to be used, there's two, there's tamoxifen and there's raloxifene. These are going to be used for two reasons, right? Sensational gynecomastia, number one. This is the real heavy-duty bro science stuff. It took me years to learn this with the great bro science guys, because doctors didn't know this stuff. They're using these drugs for breast cancer, mainly for women, but for men too. And raloxifene is for osteoporosis. That's really only for women. Of course, men can get it too, but just really marketed and just used for women. But this is not my job. So, okay, selective estrogen receptor modulators. So when you use these are used, this is a medical mistake. If you're using it for the mass, again, that's a mistake. It can be used. It can be, however, sparingly, for sensational gynecomastia when you find the lowest dose of TRT. This is how I've used it for my patients, and I don't use it for very long. And never Clomid, and I know you guys are watching this, you guys that are the astute bro science guys, you're like, who the hell is going to think to use Clomid? Guys, I see all this stuff all the time because it's a mess out there. It's a mess. That's why I made the channel. This is what you get with the Anabolic Doc app. Number one, a digital history and physical exam. Number two, weekly Zoom meetings with me. Number three, discounted commercial labs. Number four, weekly member-only uncensored videos. Number five, Anabolic Doc's mailbag. You can't come to the meetings or you don't want to come to the meetings, you ask a question, I'm going to respond to your question by making a video, put it back up on the app, and you get to see your own question. Lastly, diagnostic and management library that is easily searchable by keywords. Tamoxifen really can be used, and also raloxifene. I just happen to like raloxifene, even though it's not FDA cleared and it's not even utilized really for on the breast itself. It's actually for osteoporosis, but it is a SERM and it works very well for men that are suffering with a sensational gynecomastia. I know, guys, I know they could use tamoxifen too. It's kind of like a toss-up. Let's get your opinion. Why do you think tamoxifen's better for the gynecomastia with test? Not to mention if you're using it in post-cycle therapy, you can throw that in here too. But again, there's no real data on this. It's ever been really looked at from a really wholesome approach of like a randomized, double-blinded placebo, because there's no money in it. I think there's going to be money in it sooner or later, but because there's just millions and millions and millions of people on these drugs. So, and never Clomid. Just don't add Clomid. They're going to add Clomid to maintain your testicles because they can't get HCG and they're giving gonadorelin. I just don't like that. That's just a massive medical mistake on its own. Now, the risks of these drugs that I've seen on the histories, never with me of my patients. I'm just lucky it could happen, but that's why I monitor my patients so closely and I tell them about the risks. And if the patient says, I don't want to take that drug, doc, I don't want to have that risk, well, that's the doctor-patient relationship. So venous thromboembolism, that's DVT and a PE, that's a blood clot in the legs, goes up, causes a pulmonary embolism. Now, you see the bodybuilders, guys, leave the vaccine out of it. I know the vaccine can play a role here. Let's leave it out, please. Don't hate on me for that. So when you look at what's going on here, the risks of just being on androgens, depending on who you are, you're at risk for a DVT. Bodybuilders, it happens to them. It just does, even before COVID. It's rare though, guys, it's rare. But if you're utilizing androgens and steroids, and now you're throwing into the mix tamoxifen and or raloxifene, guys, I've studied these drugs. I've talked to endocrinology doctors and cancer doctors, hematologists about this, because I've taken care of women as a primary care doctor who have been on these for breast cancer. And we were worried about, or for raloxifene for osteoporosis. I remember one particular woman, she had DVTs in her family. She would not take this. And I didn't blame her. I agreed with her, and I was probably the doctor to say, you know, this is going to be a side effect. And then we worked around it some other way, and I sent her to osteoporosis experts up at University of Connecticut. So the blood clot is going to be rare, but potentially deadly. And I've seen steroid users, because they're on so many different drugs itself, just have blood clots. And now it's going to throw that in. Next, that's rare, but be careful. Next, and if you don't want any of these things, don't do any of this. It's all gambling. What's your risk? What's your appetite for gambling? What's your number? 1 out of 100, 1 out of 8, 1 out of 1,000, 1 out of 10. That's how these numbers are working on this individual case by case, depending on what we're talking. The common side effect of this is, that's why I don't use them very long. I use them very sparingly for like 2 weeks maybe. Hit a reset button. Works great, especially raloxifene. That's for sensational gynecomastia. Guys will feel bad. They're on testosterone. Doc, I feel tired now. It's affected my mood, my libido. I feel crummy. I feel, I'm tearful. I'm just labile. I'm up and down. I'm tearful and I'm weepy and my libido's shot. I mean, again, guys, you're using these are anti-estrogens, but they're not aromatase inhibitors. These are selective estrogen receptor modulators in this region under this. This is a medical mistake where they're not used properly and they're just used too long, and the doctor or the patient or the guys in the underground, they're using them with the wrong indication, and they're just not understanding this piece right here. And in the number one position, the medical mistake, number one that I see about gynecomastia is using aromatase inhibitors inappropriately. Here we go. This is the number one thing that I see, guys, and I want to get out to you guys now that you've made it to the number one medical mistake of gynecomastia. After you understand that testosterone is estrogenic, you want to use the lowest dose. Don't go for that 200 a week. And you guys, you don't need it. I'm just telling you. If you want to win bodybuilding shows and powerlifting shows and all this yeah, you're going to use probably even more than that. And if you're young and you got a lot of horsepower and you're just young and you have tons of health reserve and you don't mind chewing into it, you're going to go for it. I don't recommend it. Now, I told you about the estrogen tax. So when you find that dose, the micro dose, that is just right, where you're lean, hopefully, because fatter men, the heavier you are, the more you're going to aromatize. Aromatization is also biochemical fingerprints. Some guys don't aromatize, others do. You can see what's cooking here, guys. So you want to use the lowest dose of testosterone. And the other steroids, like DHT-derived drugs, I just talked about before, that they can be anti-estrogenic. However, in that milieu, is it really going to be the drugs you're getting? Is it anti-estrogenic? And does that milieu synergy have another side effect that's not sustainable and dangerous or not tolerable for your brain or for your sex? This is the whole thing. So with here, you have to use those sparing doses, okay, of the AIs. You can use an AI. Again, for the 10th time, guys, take the lowest dose of testosterone. Try not to use AIs, because I try to think, am I giving this patient something for now, like the raloxifene or tamoxifen for a short, boom, hit a reset, pain goes away, done. Uses it maybe twice a year, but this is what I do. It's really real, but I'm in contact with my patients. This is a private practice for these guys. So, but beyond that, are you going to live on an AI your whole damn life when you're on testosterone? The answer is you better question that, because it's going to affect your brain, your heart, your tendons. You just have to think about that. So again, the estrogen tax, lower it, lower it, lower it. Don't think you're going to get deductions, because you're going to get audited. And that's going to be a health problem for you when you're on these AIs. So, okay, what are the AIs? There's 3 basic AIs. I know there's more, but these are the big world that we're in. There's 3 that are most commonly used. Anastrazole is most common. Now, this is going to really piss off some of the bro science guys, but in my opinion, it's the one that we use more commonly, and it's less toxic versus the 2 other ones, Letrozole and Xanthosine. Okay, always have to work on pronouncing that one for me. Please give me a break on that. So this one is that irreversible, or that suicide inhibition on the enzyme, the aromatase enzyme itself. So this is really, really interesting. The way these should be used, again, is not 1 full milligram, for an example, of anastrozole, half or even 0.25 if you can get that little powder capsule from like in Power Pharmacy. I'm just giving this stuff to you guys, or some compounding place. And typically in the after the cycle, you're on TRT, right? This is really not steroid information. It's more TRT, guys. You're down low, you're feeling great, you got some gyno, you're losing weight, you understand it's going to be transient, but if it bothers you and you got a mass, it's not cancer, got a plastic surgeon potentially, maybe not on speed dial, now you're going to use some AI. Teeny baby dose when after the injection, typically 2 days or 3 days when the testosterone itself is peaking slightly. If you're doing these baby microdoses every day, then you just have to think of when you're doing it. And again, this is different than the SERM. I told you about those SERMs that are just not for the mass, but for sensational. But this is the #1 medical mistake, is just blasting AIs 24/7 all the time, wiping out your estrogen completely, and that's going to be very bad. Men won't, and let's get the comments. Men won't feel good. Their HDL is guaranteed to be low. That's potentially dangerous for the heart. And power lifters and strong men, they don't use these drugs because they don't want to get a tendon rupture. They're drying agents. Again, that's when you look at the suicide inhibition type of AI versus the non-suicide. This is the bro science stuff, guys, and I'm just kind of beyond that right now, okay? I used to study this stuff years ago, and now I want to be a clinical doctor. What's real versus this and that. There's not going to be really a difference on your health on these things. There's definitely a pharmaceutical difference, and guys may use them for this and for that, but again, where are the studies on it? I'd love to get into it one day. Can you live on it forever? For the heart, for the prostate. This is complex stuff. I'm not saying don't use them. I'm saying don't overuse them. That's the #1 medical mistake, AIs being overused. Now, there's also natural AIs, DIM, vitamin D, funny enough, itself, lose weight, just losing weight's natural, and magnesium. Next, lastly, the contraindications that means who the hell can never take an AI. This is every day for me. I have to run this in my head as I'm prescribing it for my patient so I don't hurt them. So I think, who I never give this to? Guy's got heart disease, bypass surgery, stents. It's never going to come out of my pen. And if it is, it's going to be such a minimal dose, and we're going to be so tight on this together. So again, you have to understand the side effects of this. You know, the bro science guys, they're just not clinical doctors. They don't work in hospitals. They don't know this stuff. It's not on their radar screen. So that's CAD, that's coronary artery disease, or that you have it, or if you have it on a calcium score, that's like high risk. Even if you have a little bit in the calcium score, I just don't like it, guys. I'm just so scared of a heart attack. Cancer and heart disease, I'm like a little boy scared. you guys got to join me on this. And you could watch your ABCDs on the app with me, and you could really stay away from this stuff with the grace of God. Okay, who else is going to be a person that I really don't want to give this AI stuff to, even in small doses, even sparingly, is low HDL. You're a man, you're as lean as you can be, you have genes for you can't change. You're doc, my HDL is like always under 40, it's even in the 20s and 30s. That's going to be like, you're going to give an AI on top of testosterone. Testosterone lowers it, typically lowers the average guy, because the average bear is probably taking a little bit too much testosterone, but he feels good, so his HDL goes low. Then you throw on the AI, it goes even lower. It's independent risk for heart disease. And then the last part is guys that have mood disorder, that's depression, general anxiety, to any degree at all, you will see, let's get the comments, right, guys? Using AIs, even the numbers can look good on paper with the ultra-sensitive estradiol and all this, but it just deteriorates them from a mood perspective and causes anxiety, causes depression, moodiness. And then the bottom line is, in the end of the day, I told you that strength guys, strong guys, trainer guys that are training hard, like powerlifters and strong men in this, these guys, they don't want to go. They don't mind being big and puffy. They just want to be strong as shit. You know, that's why Test and Deca, Anavar, Anadrol, all these different drugs, they don't want a pec rupture, a bicep, what happens anyway. That's just the nature of the business, especially when you get older into your 30s and beyond. Nature of the beast, you're moving weights, this shit's gonna happen. But be careful. So, but if you're taking aromatase inhibitors, that's just straight up toxic to that tendon muscle, skeletal muscle apparatus. Hope you guys really like this. That's the end of the top 5 medical mistakes, understanding gynecomastia. Let's get a lot of comments, guys. Thank you so much. Get on the anabolicdocapp.com and let me help you guys out. This is what you get with the Anabolic Doc app. Number 1, a digital history and physical exam. Number 2, weekly Zoom meetings with me. Number 3, discounted commercial labs. Number 4, weekly member-only uncensored videos. Number 5, Anabolic Doc's mailbag. You can't come to the meetings or you don't want to come to the meetings, you ask a question, I'm going to respond to your question by making a video, put it back up on the app, and you get to see your own question. Lastly, diagnostic and management library that is easily searchable by keywords.